Renal cystic disease, also called as polycystic kidney disease. Polycystic disease of the kidney is a disorder in which major portion of the renal parenchyma is converted into cysts of varying size. So, the name itself is saying polycystic, multiple cysts are there present where in the kidney. Polycystic disease of the kidney. Okay. Major portion of the renal parenchyma is converted into cysts of varying size. The disease occurs in two forms. One is adult polycystic kidney disease, autosomal dominant, and the other is autosomal recessive polycystic kidney disease. In ADPKD, that is autosomal dominant polycystic kidney disease, the inheritance is autosomal dominant, and ARPKD is autosomal recessive. The cytogenetic defect that occurs in ADPKD is chromosome 16 most of the times because of the ADPKD1 gene, and chromosome 4 because of the ADPKD2 gene. And in ARPKD, that is autosomal recessive polycystic kidney disease, it is chromosome 6 that is defective. Coming to the mutations, PKD1 gene, as I said earlier, 85%, and PKD2 gene, 15%. Coming to the childhood disease, that is autosomal recessive polycystic kidney disease, it is 6p21 PKHD1 gene. Coming to the incidence, ADPKD is seen in 1:400 to 1:1000 ratio incidence is, whereas the incidence is 1 in 20,000 for ARPKD. Age at presentation will be, the name itself is saying, it is seen in autosomal dominant. So it will be seen in the adults, 3rd to 5th decade. Autosomal recessive, it will be seen in the infancy and perinatal period. On gross examination, the enlargements will be in ADPKD, it is symmetrical bilateral enlargements, and there will be macrocysts as shown in the picture. Macrocysts. See, all big cysts, macrocysts. When we see the gross examination of a ARPKD, that is autosomal recessive polycystic kidney disease, which is seen in children, there will be microcysts and macrocysts radiating from the medulla to outer cortex. They are radiating from medulla to outer cortex. The kidney is enlarged, sometimes asymmetric and sponge-like. This is the characteristic feature of ARPKD. Coming to microscopic examination, the cysts derived from all parts of the nephron. Glomeruli are involved, tubules are involved. Whereas in ARPKD, cysts are from dilated collecting ducts. This is the difference between ADPKD and ARPKD. Glomerular tubules are involved in ADPKD, whereas the cysts are derived from the dilated collecting ducts in ARPKD. Other manifestations will be, in ADPKD, there will be intracranial aneurysms and cysts in the other organs like pancreas, lung, and etc. Such manifestations are not seen in ARPKD, autosomal recessive polycystic kidney disease. So here macrocysts, here micro and macrocysts, but radiating from the medulla towards the outer cortex. This is symmetrical and this is asymmetrical. This is cyst derived from all parts of the nephron. Here cysts are derived from dilated collecting ducts. Other manifestations are seen in ADPKD, whereas they are not seen in ARPKD. Gene involved is PKD1 and PKD2 in ADPKD. It is PKHD1 6p21 in ARPKD. We will discuss adult polycystic kidney disease. This can be asked for a 6 marks question or a 3 marks question. Most of the times in the universities, they will ask you renal cystic diseases or cystic diseases of the kidney. Then you have to write both the autosomal dominant and autosomal recessive polycystic kidney disease. Adult polycystic kidney disease is a autosomal dominant and mutations are PKD gene which encode for polycystin protein. PKD1 is gene is located on chromosome 16 and it is seen in 85% of the cases. PKD2 gene is located on the chromosome 4 and it is seen in 15% of the cases. So, main mutation is PKD1 followed by PKD2. And adult polycystic kidney disease is always bilateral and diffuse. You have to remember this point at any cost. Bilateral and diffuse in adult polycystic kidney disease. They are abnormal at birth, renal function is retained, and symptoms appear in adult life, that is around 30 to 50 years. Kidneys are bilaterally enlarged, symmetrical, lobulated appearance on external surface because of the macrocyst. The cut surface shows cysts throughout the renal parenchyma varying in size from tiny cyst to 4 to 5 centimeters in diameter. And these cysts will not communicate with the pelvis of the kidney. This is a very characteristic feature of ADPKD, polycystic kidney disease. The cysts will not communicate with the pelvis of the kidney. Whereas in hydronephrosis of the kidney, when you see on section surface, the cysts will communicate with the pelvis. So, in hydronephrosis, there will be communication with the pelvis, but whereas in polycystic kidney disease, there will not be any communication for the cysts with the pelvis. This is the identifying feature to differentiate or distinguish the hydronephrosis and a polycystic kidney. Other features, about a third of the patients with ADPKD will have the cysts of the liver. So, associated congenital anomalies seen less frequently are cysts in the pancreas, spleen, lung, and others. As I said earlier in the previous differentiation table, in ADPKD, other manifestations are present. Intracranial aneurysms are seen in ADPKD, which are not seen in ARPKD, that is autosomal recessive polycystic kidney disease. Coming to the infantile polycystic kidney disease. It is infantile polycystic kidney disease or autosomal recessive polycystic kidney disease. And it is because of the PKHD gene, PKHD1 gene located on the chromosome 6 and it encodes for fibrocystin protein. Okay, fibrocystin protein chromosome 6 PKHD1 gene, infantile polycystic kidney disease or autosomal recessive polycystic kidney disease. It is always bilateral, presents at birth and results in death from renal failure in the early childhood. Grossly, the kidney will be enlarged bilaterally with smooth external surface and it will retain its normal reniform shape. But when we do cut or on cut section, the cut surface will reveal small fusiform or cylindrical cysts that are radiating from the medulla and extending radially to the outer cortex. So, from medulla to cortex, these cysts will be radiating and this will give the sponge-like appearance on section. No normal renal parenchyma is grossly recognized in infantile polycystic kidney disease. Pelvis, calyces and ureters are normal. Okay. Other features will be sometimes multiple hepatic cysts and congenital hepatic fibrosis is seen in infantile polycystic kidney disease cases. So, this is a chart differentiating between adult and childhood Polycystic kidney disease of two types or two forms. One is adult form and the other is childhood form or infantile form. Adult form is autosomal dominant, childhood form is autosomal recessive. Mutations in PKD1, PKD2 gene which will encode for polycystin protein are the cause for adult PKD, whereas the mutations in PKHD1 which will encode for or produce fibrocystin protein is the cause for childhood PKD. Asymptomatic till middle age adult PKD, whereas it is present in infancy with renal insufficiency in childhood PKD. Clinical features will be there will be hematuria, hypertension, urinary tract infection, and renal stones in adult polycystic kidney disease. And there will be extrarenal manifestations like cysts in liver, lung, pancreas, spleen, ovary. There may be CNS aneurysms, that is berry aneurysms, colonic diverticulae, mitral valve prolapse, aortic regurgitation. Whereas childhood PKD is associated with multiple hepatic cysts. You have to remember this. Multiple hepatic cysts and congenital hepatic fibrosis in childhood PKD. Grossly bilateral enlarged kidney is present in both adult PKD and childhood PKD, but there are multiple cysts containing serous or hemorrhagic fluid in adult PKD, whereas the cysts which are present, they are microcysts present in the cortex and medulla, having their long axis at right angle to the capsule in childhood PKD. There will be no communication with the renal pelvis in polycystic kidney disease, and in hydronephrosis there will be communication between the cyst and the renal pelvis. Thank you for your patient listening. Please like, share and subscribe Dr. Ravichandra Official for more such interesting videos on pathology.